Good afternoon. On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Outside the Box Webinar Series, Patient Reporting System and Complaints. My name is Kelly Gibson, and I will be your moderator for this program. Now I'd like to introduce our speakers for the webinar. Melanie Motz and Megan Shetterly are both Senior Patient Safety Liaisons with the Patient Safety Authority. Both Mel and Megan interact with patient safety officers and other various healthcare staff to identify safety hazards and risk and reduce patient harm. Christina Lauro is the Director of Quality Initiatives and Patient Safety Officer at Doylestown Hospital. Chrissy worked as a clinical RN at the Children's Hospital of Pennsylvania before transitioning into an administrative role. Since that time, 21 years ago, her professional work has been focused on patient safety, performance improvement, advancement of care excellence, assurance of regulatory compliance and accreditation, as well as the advancement of patient satisfaction. Terry Simon has been a nurse for over 35 years. Her clinical practice began in the emergency department and then the NICU. She later became a flight nurse, a trauma educator, a case manager, a legal nurse consultant, and now serves as the risk manager and patient advocate for Doylestown Hospital. And she is still happy to be a nurse. Bernice Edwards is a patient advocate manager for Reading Hospital and Reading Hospital-based ambulatory clinics. Bernice has been with the Reading Hospital for 6+ years and currently serves as the liaison between patients, their families, and clinical staff to obtain solutions to concerns, complaints, and unmet expectations for service and support. Mel, I will now turn the program over to you.
Thank you, Kelly. Good afternoon, everybody. Welcome to Outside the Box webinar series, Patient Reporting Systems and Complaints. We have a great presentation for you with the guest speakers from Doylestown Hospital and Reading Hospital. But before we get started, I'm just going to review our objectives. Our first objective is to understand the historical and current context of gaps that exist in medical error reporting. We're going to learn about feasible and simple patient event collection systems that can produce large gains in your facility. And we're also going to recognize the value of integrating a patient-centered approach into your existing repository of reporting sources. As Kelly said, we encourage you to use the Q&A box section to address all panelists. So any questions you have as the presentation goes on, we have a lot of time at the end of the presentation to review your questions. Wrong way? Okay. So to get us started, let's define what an adverse event is. So according to the OIG, an adverse event is harm to a patient as a result of medical care or in a healthcare setting, including failure to provide needed care. For those of you who are not familiar with the OIG is the Office of Inspector General, and their responsibility is to oversee compliance of health and human service programs such as Medicare to prevent fraud and abuse. And they do this by conducting independent audits and inspections. So in October of 2018, the OIG reviewed a random sample of 770 hospitalized Medicare patients discharged from an acute care setting. This study was compared to a 2010 OIG study, and it was essentially conducted to update the national incidence rate of adverse events. And their findings include what you see here, that 1 in 4 hospitalized patients experienced harm, and that 43% of adverse and temporary harm events were preventable. And they did this through nurse screenings and physician review using a trigger tool. To read more about this report, you can click on the link at the bottom of the slide there. A 2012 OIG report found that only 14% of patient harm events were reported into the internal incident reporting system. So what about the remaining 86%? Are we capturing everything? Are you validating other sources of data? These are some things to think about. So how did the OIG identify adverse event? They did this by medical record reviews and the use of a global trigger tool. Nurses were involved using the tool, and that stage 2 of that was going to the physician review. So this global trigger tool was originally developed by the IHI, the Institute of Healthcare Improvement, to systematically screen records for triggers or clinical cues that indicate patient harm. And here are here's basically a summary of some of the sources that can be used for event reporting. And this is what our outside the box webinar series is about. Our colleagues, Chris and Kathy, reviewed billing data and IC10 codes last month in January. Today, we're talking about patient reporting systems. In the next couple months, we're going to touch on trigger tools, medication technology, media and publications. And this is why we put this series together, to introduce or review some other data and reporting sources. So when you're assessing patient safety initiatives and performance improvement ideas, you have some actionable ideas or strategies to consider. I'm going to now turn the presentation over to my colleague, Megan.
Thanks, Mel. So now I'm going to talk to you and share some information about the current and the historical context of gaps in medical error reporting. Mel already shared some of that. I'm going to get a little bit more in detail. So over about the past 20 years, there have been multiple surveys and studies that have shown anywhere from really about 1 in 3 to about 1 in 5 patients experience medical errors. There have been other studies that have shown anywhere that from 13% to 93% of events were not reported into healthcare facilities' patient safety reporting systems. So in essence, the result is a huge knowledge gap, and you cannot fix what you don't know. So why don't we know? Well, there could be many reasons. And one is that healthcare event reporting collection systems were designed for healthcare providers and healthcare workers, where the patient's perspective is typically not solicited or incorporated. So this is leaving the potential for underreporting. So we can learn from patients and families and really think about this. Here are some questions that you can ask at your next patient safety committee meeting. Do patients and families tell anyone about their experience with care? And does anyone ask for this information? So many of you maybe are already doing surveys like Press Ganey or some other internal surveys, but maybe this isn't giving you all the information that you need. And let me give you an example. One of the studies that was done and published in 2019 came from the Betsy Lehman Center for Patient Safety in Massachusetts. And they found that 40% of those patients who they interviewed who said they had a medical error only told their family and close friends. So that information never got reported to the provider or to the facility. So the one consistent person involved in every aspect of care is the patient. She or he is witness to everything from visits to their PCP, picking up their medications at the pharmacy, to seeing specialists, having labs drawn, procedures performed, and really just experiencing their overall healthcare experience. They are astute observers. We can learn from them, but how do we get this information? Well, we are going to learn some innovative strategies from two healthcare facilities, Doylestown Hospital and Reading Hospital. So to kick us off, Chrissy Laro and Terry Simon are going to talk about their process for patient outreach and integrating their experiences with patient safety events into their patient safety program. These are simple processes that produce large gains. And so Chrissy and Terry, I'm going to hand the program over to you.
Thanks, Megan. This is Terry. I'm going to tell a little bit about our culture here at Doylestown Hospital, about Doylestown Hospital itself, and I will talk a little bit about our PFAC committee. There we go. So we are founded in 1923. We're in our 100th year. This is our 100th year celebration. Doylestown Hospital is one of two hospitals in the United States that was founded by a group of women. We have the Village Improvement Association, and they still participate in governance of the hospital, and they have a vital presence in everything we do. We're a 247 bed community hospital, and we are still independent. So we started a patient and family advisory council a little more than 8 years ago. And it was initiated actually before I came to this facility, but there was really very little input from the community members at that time. We were actually kind of presenting to them, and there was really no forum for questions, for problem solving, that kind of stuff. Shortly before COVID, we stopped the meeting briefly. It didn't feel productive. There really wasn't a lot going on. We had some community members leave. And then we had a leadership change and a whole new focus for PFAC. So we reinstituted the meetings, contacted the members, and at first there was some hesitancy. I'll be honest, this was the worst meeting I ever had to go to prior to this reinvigoration. It would be 2 to 3 hours. It seemed like talking. It wasn't productive. So when we reinitiated it, we weren't really sure what to include. But then we had more community members join, and there was, a lot of different people involved. There were professionals, there were community members, there were moms and patients, and so now we have 15 members. 8 are from the community, and we're still actually recruiting more. And our core concepts are dignity, respect, information sharing, participation, and collaboration. We have a PFAC committee that is very much engaged at this point. So this is our evolution of sorts. In March of 21, we resumed our meetings, and the individuals that are part of our committee, very, very motivated, highly motivated, and they really are interested in changing culture, safety culture in the hospital. In June, we decide to focus on patient advocacy, and this is the sole focus at that time. And they use the Institute for Patient and Family Centered Care as a resource. It really came from an experience of one of our committee members that she had in New York with a New York PFAC, as a family member of a patient. She had an experience with their PFAC committee, and really was, inspired to generate a lot of energy within ours. So we used resources, we developed a plan, and we decided that this is what we wanted to do. We wanted to focus on advocacy. We did a presentation to our senior leadership council because we knew that we needed their buy-in. Without it, we wouldn't be able to move forward with this for a systemic culture change. So we got their buy-in. They loved it. They loved the presentation. Our community members actually were the ones that presented. We supported them through it, but they took the role over, and we started to work on our website. So in January 22, we started working with marketing and education department, looking at what we have, what we needed, and what we could improve on. So on November 4th, our website went live, and there was a whole lot of celebration, great feedback. We have evidence that the site is being used. We've had some people call in, using the information we've listed, calling in with compliments, concerns, feedback on questions for all kinds of things related to patient advocacy. So we know that they're using it. And then in December, we initiated a blog, and it was solely instituted by a community member. It's really from the patient's perspective. So this is what our website looks like. This is actually selected from the initial patient web screen, and not web screen, website, I apologize. And you can see where the red circles are, that is what the person selects to go into either the patient and visitor section, which provides all that information below regarding visiting, billing, patient portal, patient advocacy, and then the blog is listed. So that is always listed. That is the ribbon at the top. It's always there. So for the topics, our topics that we have on this are advocating for yourself, advocating for a loved one, advocacy services at Doylestown Hospital, what we offer to them, core concepts, your care team, and visiting a patient. And under each section, there's really good information that's valuable and, not too fancy. It's been health literacy approved, and it seems to be working. We also have on our website a recruitment section for new members. Let's see, what else do we have? We have, our blog is from a patient's perspective. This is what I mentioned before. And we talk about, how PFAC works, and what it hopes to accomplish, and how to, our next step that we've decided for PFAC is going to be communication, working on communication throughout the facility with the care team, with patients, with administrators, medical records, everything. So that is our next goal, so to speak. And now I will turn it over to Chrissy.
Thanks, Terry. So along the lines of teaming up with PFAC, as this has become such a vibrant group within our hospital organization, we then do need to think about how are we going to get these events and better leverage even our PFAC group for handling of these events too, because I do see them as a great resource. So, in patient safety culture, it's been well established that we need to be listening to our patients and our families. And I put in here, I mentioned Val King, and for those of you that don't know her name, go ahead and Google her, tons will come up. But, she was a mother of a baby that died because of an event. And it's kind of nice. I was at the IHI conference where she famously during the conference said, when they were talking about rapid responses, and she said, well, why can't a patient or family call for a rapid response if they feel like something's going on? Because she feels that would have saved her daughter, and it could have. So now we move forward, and that happened years ago, but, and so there's been a lot in the literature since, and most recently, or most visibly, I should say, I'm sure there's been somebody wrote since that time, but in 2020, there was this national action plan to advance patient safety that was written by, an IHI collaborative. And it's a really powerful document. And they have a whole section in there about patient and family engagement. If you look at that number 7, it specifically is calling on us, the healthcare providers, to involve and include our patients and family in safety and improvement efforts. And I just think that that's such a vital aspect. But, you say, okay, well, how do you get that? And what can we do to get that information and to make them feel engaged and let them know that we do want to hear from them? So, there's been some different ideas that were suggested. I've been at Doylestown now for about 3.5 years. So at the time I thought, okay, well, let's think about adding something to our website for suggestions for safety and quality and saying, hey, we want to hear from you, and developing something in a different realm. And I even had a crazy idea like, oh, let's just have an open hour and we can serve like tea and crumpets. I don't know what I was thinking, and, invite them to come. And then COVID happened. So of course that went away. So we couldn't really do that. So how do we get that information from our patients and families? So there's a lot of opportunities that we currently we had back then and we're building on currently at Doylestown. Complaints and grievances come at you whether you want them or not. People are going to complain. They're going to throw out their grievances. And luckily here at Doylestown, they go to Terry. So I can just be kind of like, a help when things have a safety or quality component. And, we really should be listening to those complaints because there's a lot of information that comes through. And even if it's just the volume of it, like, hey, people are complaining that they have to sit on the COVID line for 2 hours to get an appointment. Well, that tells us people then aren't getting the care that they need. So listening to those complaints and grievances and digging into them in a different way can give a lot of insight as to how we can do better as a health system. We do have a Contact Us Hospital website, and previously it had all kinds of opportunities, and I'll share with you where kind of like, patients and families can click on that in the website and look for quality components and safety concerns that they have in there. Another huge opportunity is in the Press Ganey comments. And again, it's whether you want to read them or not, but they're going to tell us how they feel. And in looking at some of those comments, you can really learn where your opportunities might be. And then, of course, there's always direct calls. Somehow somebody is going to figure out that my phone number is 2027 and they're going to call me, or they're going to call Terry, or they're going to call administration, which if there's anybody from administration on this call, I'm going to apologize, but they then will forward it because they don't know what to do. So they're going to forward it along to us. So these are some of the intakes that we had that we were paying attention to and looking at from that other component. So here's an example. In Press Ganey's survey, looking at these comments, there was a woman, and it just, I just really felt for her. She has very sensitive skin. She would come in for MRI and outpatient procedures and, very much always use Doylestown. She's our neighbor, she lives in our community. And every time paper tape, the peripheral supplies that would be sensitive to be used for her, we wouldn't have them. And she would experience skin tears and rashes. And I think you can identify that even in your own areas. We may not have a lot of those supplies out there. So she started bringing in her own. She would go to a drugstore and she would pick up what she needs and she would have it in a little pouch and she would bring it along. Well, that's a terrible thing. I just think that's a terrible thing. So in calling her, just because she put her name and her phone number on the Press Ganey survey, we had a lovely conversation and she said, yeah, this is just what I need. And is that really too much to ask? And I'm like, no, it's not. So partnering with central supply and outpatient departments to make sure that we stock those appropriate supplies in the outpatient locations. And, that helps this woman, but it also helps others who probably just never took the time to put that on a Press Ganey survey. Another opportunity that we had, there was discharge paperwork for another poor man who we ordered eye drops to be used sublingual. So if that's confusing to you, it's definitely confusing to them. The patient and family, went home and they started administering it in his eye, and he was experiencing blurry vision because of the dosage. So it gave us that opportunity once we heard this direct feedback from them, let's take another look at our discharge paperwork. And we, saw obviously some opportunities to make it more patient friendly in its language. And we did take it to PFAC and that PFAC committee. And even this was back, probably about a year ago. And the PFAC group that was there was like, yeah, this is hard to understand. We don't know this language. So I included what the current wording was back then, and then what PFAC, proposed as a change. And even the word oral, it was kind of amazing because we use it and you think, oh, everybody knows oral. It's out there in the community. It's not just a medical term, but they even said, well, even that could be confusing for some people. So you'll note we made the change to say by mouth. And be more descriptive in all the other ones because it's too much. And if you can't, I didn't really kind of blast it past it, but when you look at that insert, you can see that's from his discharge paperwork. And we do, one drop sublingual. So we are using the words that are just a little bit too tough for our patients. So recently in our Contact Us page, we did add an additional choice. So you can see what was there already. It's that your reason for contacting Doylestown Health in the blue. And then they had all of those other choices already, but we added quality safety concerns or suggestions, because I do think that, in talking with Terry and in talking with others in marketing, it's like it could help to kind of jostle them a little bit and say, oh, wait, they're wanting to know from us. They want to hear what we have to say. So I'm going to put it in there. So again, this just went live, like 3 weeks ago. Mm-hmm. So far, we've gotten 2. Neither one was what we were looking for. But, it's at least showing that people are seeing it. And we're going to hope to see how we can better advertise that this exists. But the process will be that once they submit, we end up getting it and it comes to me, and it also actually comes to Terry, and I think it comes to our director of risk. We can then evaluate between us as to what that looks like and who's going to take it. And if it is an event report, or event report worthy, if you want to call it that, we'll put it in as a safety event in the same system that we use for our patient or for our staff members. We have our event reporting system through the Meditech, And, we in fact just added a choice that we can say who reported the event. Because if it's somebody internally, they can easily just through their log on, just, say, oh yeah, it's me. But there is that opportunity to say who actually reported it initially. So we've added that choice to say patient or family. And then that way, this event goes through our same process to be, evaluated, determine whether or not it should go on up to Pacers, and then also to do whatever follow-ups we need to do and treat it just like we would if our associates had entered that suggestion. And in fact, I'll tell you just off the side, we recently did get, not through our contact us page, but we recently, like last week, got a complaint from a family member. And in that big complaint that she wrote, there actually was a care concern issue that she raised. And it actually fulfilled the requirement of a series event. So we did actually put it into our system and we did report it to Pacers. And of course, we're doing follow-up. I just need to say that, of course. So what are our future possibilities? We currently have a phone number that my department mans, the quality department mans, for event reporting by associates. And that's really done just because not everybody has access to our event software system because it's linked to our EMR. So this gives people an opportunity that they can call on the phone for a reporting of an event. And we were thinking, well, we could share that with our patients to give them that opportunity, because sometimes people prefer to just pick up the phone and leave a message. But, consider it that in a different organization that I was at, we had that. And we would not, it was mainly wrong numbers. People didn't really use it for that. But maybe with the right education or the right sharing of the information, we could make a little bit of a better impact. We also are thinking about including the information in the patient folder for reporting events or near misses and giving a little blurb around, we want to hear from you and please tell us, how we can improve and if you identified any of this, because it is important to us. And then giving them the information is to say, hey, here's the phone contact, here's an email, and then even directions to the contact us area of the website as well. So that's kind of where we're thinking we will go. So Terry and I want to thank you very much for your attention, and we will now turn the program over to Bernice from Reading Hospital.
Thank you, Chrissy and Terry. All right, so we're just going to start with a little facility overview. So Tower Health is a regional integrated healthcare system that offers compassionate, high quality, leading edge healthcare and wellness services to communities within Berks, Chester, Montgomery, and Philadelphia counties. We have approximately 11,500 employees across the health system, and they consist of Reading Hospital, Phoenixville Hospital, Pottstown Hospital, and St. Christopher Hospital for Children in partnership with Drexel University. So founded in 1867, Reading Hospital is the flagship hospital. It is magnet recognized and is an acute care hospital that's located within West Reading, Pennsylvania. So we have a 697-bed hospital. It is home to many top-tier specialty care centers, including the Reading Healthplex, which is an advanced and comprehensive surgical care unit, the McGlynn Cancer Institute, which includes an image recovery center and a cancer infusion center, the Miller Heart Center, and an emergency department that includes a level 1 trauma center, and the trauma center is the first and only trauma center within the Berks County area. And also the Beginnings Maternity Center, which houses the region's only level 3 neonatal intensive care unit. Reading Hospital has been recognized for its quality outcomes and clinical expertise across the service lines. Healthgrades has also recognized Reading Hospital as one of America's 50 best hospitals for the second year in a row, and has been in the top 1% nationwide for overall clinical performance. Prior to that, Reading Hospital is also recognized as one of America's 100 best hospitals for 7 consecutive years. So to discuss our patient advocate team, our team consists of our director, the manager, which is myself, and 2 patient advocates, 1 full-time and 1 part-time. We also have our director and another staff member who have both a dual role as an interpreter and are both certified through the Barrel Institute as a patient advocate. In coming slides, we will further discuss our staffing and additional challenges we have faced due to the COVID pandemic. So the areas we serve are within the hospital include all hospital units as well as any hospital-based clinics and practices. As listed here, we have roughly 8 areas that we serve along with the hospital. So we serve the Tower Health Family Healthcare Center and the A4 Clinic, which provides a variety of outpatient services, the Women's Health Center, the McGlynn Cancer Institute, the Center for Public Health, the Center for Mental Health, and our neurology and infectious disease offices. So our journey has been a bit challenging, but we have been able to persevere. During the pandemic, we struggled with uncertainty, and really we were just restricted from doing our usual workflow. We were unable to connect with patients face to face, which affected our daily rounds and family meetings. We suffered severe staffing challenges. We actually went from 6 patient advocates down to 1. And that was in combination with organizational decisions as well as employee decisions. So that ultimately resulted in 1 patient advocate to serve all assigned areas. So with 1 patient advocate, we realized that, there was obviously a increased volume of reports. It became challenging to handle it, so we were unable to connect with patients and family and their representatives due to certain restrictions, including visitation restrictions. So due to those challenges, we had to think of innovative ways to reach patients and their representatives. We had plenty of assistance from in-house clinical staff and leadership who assisted with and addressed patient concerns and complaints before the patients were discharged. So that involved staff just checking in on their units, following up with their staff, especially nurses who have close interaction with those patients, just to ensure that their needs are being met. We have also seen an increased collaboration from the leadership team and our patient advocate department, just to ensure that our patients do receive the best quality of care. Regarding the visitation challenges, we were able to coordinate with admissions in additional departments and implemented a patient information line. This was a big help to staff and a satisfier for patients and their families and loved ones. So with handling updates and providing quick patient information. So although we're not in the clear with the pandemic as yet, some restrictions have been lifted and we have been slowly but surely getting back to our usual practice and workflow. Since then, we have been able to increase our team to include 1 additional full-time and 1 additional part-time patient advocate. We have gone back to rounding on patients, and these are generally scheduled based on the advocate schedule since we have a full-time and a part-time. Generally, when we round, we go to the unit floors just to check in with the unit director to see if they have any concerns or if they recommend us go visit a patient. If the unit director is not there, we generally follow up with the facilitator of that unit. When we visit the patient rooms to check in with those patients, we just ensure that that their expectations are being met or to hoping to address any concerns that they may have. If there are no suggestions from the staff, we generally continue to still round on that unit. We'll just pop our heads into the rooms just to ensure that just to ask about the patient's stay and then provide patient advocate information and our business cards in case they would ever need our services. We also receive patient concerns and complaints from our web services department. If there are any messages or reviews on any of our social media platforms, a message with the patient advocate office information is sent to that reporter. If there happens to be any identifying information from that review, we'll generally attempt to contact the reporter via phone or email or the preferred method of contact. We have a complaints and grievance process where families can submit their complaints via phone, email, or by mail. Our grievances are reviewed bi-weekly, and we have a grievance committee that includes individuals from physicians, nurses, patient safety, risk management, and quality leadership teams. The team collectively reviews grievance cases and identifies any opportunities there may be for improvement. And then after an investigation or just a review of the grievance is complete, we do inform the reporter of the outcome and follow up with any of their additional needs. We can also receive reports from staff members within the hospital. So if they feel that a patient will benefit from speaking with an advocate, we also encourage staff to reach out to us as well if they are having difficulty with a patient, just with any difficult conversations, just for guidance and support. And we've received quite a good amount of interaction surrounding that. So our department also collaborates with and receives referrals from our risk management, patient safety, compliance, and billing departments based on certain cases that they believe the quality of care needs to be reviewed and reported as a patient grievance. We definitely collaborate with them and come to a resolution for the patient. All right, so examples of our gains. We collaborate with patient safety and to identify opportunities to improve patient care. So now we participate in our hospital's patient safety committee meetings, and we do present a grievance update biannually. So this update usually includes the number of grievances that are reported, the top cases for the fiscal year, and any outcomes, the top 3 categories as well, and any outcomes of the grievances reported. So during one of our biannual reviews, we noticed an increase in concerns reported relating to lack of oral and personal hygiene from patients and their families. So in collaboration with nurse leadership and patient safety, there have been changes in re-education in nurse clinical practice. Another example is a reported grievance that involved a pediatric circumcision. So this resulted in strong collaboration with risk management, patient safety, and physician leadership to evaluate practices. We also have identified that there was a gap in educating staff on how to appropriately handle pediatric patients with mental health disabilities, especially in emergent situations. This resulted in a collaborative effort with the Chief of Pediatric Emergency Medicine and our System Vice President of Diversity, Inclusion, and Community Wellness to introduce education to clinical and non-clinical staff on how to appropriately and effectively handle these situations when they arise. Thank you all for your time. Megan, I will now turn the program back over to you.
Great, thanks so much, Renice. I appreciate it. And Terry and Chrissy, great presentations. You know, these are very simple processes and systems that have been introduced in both of these settings, which you can see have produced really large gains. And I just have to say, because, you know, we do have, you know, some time here, both Mel and I wanted to give both of these healthcare facilities enough time to share their information. And then certainly at the end, have enough time for Q&A for people that might be interested in asking questions. And they provided their contact information if you wanted to reach out to them afterwards, which, you know, we obviously would encourage you to do to learn about their processes. But one of the things that, you know, Mel and I have learned, and, you know, just kind of diving into this, to look at systems and processes that exist that are out there in the literature, we'd found that the Agency for Healthcare Research and Quality, which is also referred to as ARC, had actually done a lot of work on this a few years ago and pilot tested a pretty comprehensive, and I want to say complex, program, which honestly had a lot of moving parts and I think had a lot of challenges. I mean, just setting up the infrastructure alone for a patient reporting system for patient safety events. It was, I think, a huge undertaking. It was a research project that they piloted in a number of healthcare facilities across the United States. And if you are interested, if you go onto their site, you can see the results of that information. They published a paper that gave all the specs on that and what the outcomes were. And they did see some gains. They did notice that, in fact, they were getting reports in from patients. It was more robust because they were able to then, you know, reach out and have conversations with the patients, just as I think Chrissy and Terry were explaining in their program, where they would get, you know, reports in maybe from Press Ganey, but then they'd reach out to them. For instance, that I think the woman that either Chrissy or Terry, you were saying that had, you know, skin sensitivity issues and was bringing in her own product, but you reached out to her and you had a conversation. So in that sense, the ARC program, you know, it did produce some large gains in their pilot program, but so many challenges. Just the infrastructure alone and the resources, the staff that had to staff, they had a hotline, they had a website, they had actually an electronic system for patients to report into, you know, the campaign to educate patients. I mean, just so many layers, HIPAA, you name it. And it was very interesting read. But I thought to myself, and as Mel and I were putting this program together, what are some really simple things that people are already doing in healthcare facilities that we could reach out to, that could share their information? And even Renice, as she was talking, you know, I was really struck when we had first reached out to Renice to ask her to talk to us about, you know, the whole challenges, obviously, you know, with the pandemic and how the resiliency of her and her team and how they responded to that at that healthcare facility. So, in essence, they didn't give up the ship. Like, they're still doing it, and they found ways to kind of mitigate their efforts to make sure that they still get those large gains. And in both of these facilities, what they're doing is not only getting the notification of what's going, not only reaching out and having the conversation with the patient, but bringing that information back to their PFAC, to their patient safety committee, so then they can do something with that information. And the facility at large is learning about this and moving forward with maybe not even education, let's just say in the emergency department, because I think, Renice, that's one of the things you pointed out, that there was some mental health challenges by a patient that really weren't being addressed in the ED. But then, you know, you end up doing a more broader education on a larger scale because that patient may not only be met with and cared for in the ED, there may be other departments. So I think there's so much value, and again, I'm just going to stop talking, I guess, so we can open this up for Q&A. But there's so much value to be learned from this. And this quote, I think, is very poignant and points that out. Patients' insights have the potential to help guide the institution toward meaningful patient safety improvements in the healthcare system. And if you are interested in any of the resources that we had used in order to formulate this particular presentation, they are available here, and they should be in your handouts as well. And all of these are available on the internet, so they're easily accessible to you. But the one that I was mentioning was the ARC, and quite honestly, this first one that's listed on here from ARC that I was talking about, that program, this is not that one. And I apologize, but if you do just Google that for patient safety reporting systems and you want to find out about that pilot they did, that's available on their website. So I'm going to stop talking so that we can open this up for Q&A, and I'm going to hand it over to Kelly.
Thank you, Megan, and thank you to all our presenters. That was a lot of great information. So this concludes the slide presentation portion of our program. We want to begin the question and answer period. So if you have questions, please type them in the Q&A box found at the bottom of your screen on the right-hand side. If you do not see the Q&A box, click on the 3 dots that are in the very far right bottom corner, and then you'll be able to get to the Q&A panel. Direct your questions to and we will get to as many as we can. I wasn't seeing anything actively come through, but at this point in time, we do have one question. What do you recommend as a first step for facilities that want to start a patient reporting system?
Do you want me to take that? This is Terry. I think it's really you know, soliciting a community involvement to see if, you know, to get interest, to you know, because you need the outside participants. Initially, we tried to solicit people who were essentially the complainers. You know, to bring them in to see how they could contribute to making things better or making a difference. And sometimes that worked and sometimes it didn't. We had some members that just wanted to keep complaining. But that was kind of a start, you know, and I think it's identifying your audience, your community, and what are your resources within the hospital to kind of bring patients and families into the facility for this type of, you know, this type of improvement.
Yeah, and this is Chrissy. I would add on to that. I think that's a great first step. I would also say too, like, look at the inputs that you're currently getting. You know, organizations are already getting information from their patients, and just looking at it from a safety quality lens, and that could be a great source of input as well.
Mm-hmm.
Thank you. That's great information. It looks like we have kind of a question related to, I think this is a product. Does anyone use SafeLink for staff input? If so, is it possible to make it available to patients and or families?
We don't use that.
Mm-mm.
No, we don't use that either.
And
Sorry.
if there's anybody that has any more information on that, that you can type anything in the Q&A, that would be helpful as well.
Kelly, it's Megan. I just have a question I wanted to put out there too. We were actually going to do a polling question, but we didn't know if we had enough time. And so I actually am going to ask that now, if people don't mind, to put this in the chat box or the Q&A box, either one. Does anybody have a process that they are using, either what we talked about today or something different? Because like I've never heard of SafeLink. I don't know what that is, but that's very interesting. So I'd be curious to know if there's other things that people are doing out there.
This one says, for those of you who have patients and families involved with your processes and committees, do you have them sign anything related to confidentiality?
Yes. Yes, they sign confidentiality statements. That is a requirement to be a member on the PFAC committee.
Right, and it looks like somebody needed the question repeated. I think that's related to Megan, what you're questioning in line of input from the facilities or participants on the webinar. Megan's question had been related to, does your facility currently have a process or some sort of system in place for patients and families to report patient safety events? So if anybody would like to give some response related to that, you can type that in the chat up in the very, on the right-hand side. As we're waiting for any comments to come in, we also, it looks like, had another question come through. Does anyone use patient family feedback tools around quality process metrics like hand washing?
Yeah, this is Chrissy and Terry. We're not quite sure what we mean by feedback tools.
They use the example hand washing, and I don't know if that's just doing direct observation type of thing.
Oh, I see she says here like an app. Maybe it's an app to give feedback about patient and from patient and families if staff are washing their hands. Maybe that's what she means.
That's exactly
I don't
what I
think
was
that we are currently using anything like that. Not that I'm aware of.
I see another question in the chat box here. It says, how are hospitals incorporating the leapfrog requirement of having patients be a part of the quality and safety committee while also having a PFAC?
Well, according to MCARE, you are supposed to have some community members. So that's within your patient safety structure. And then yes, like having a separate PFAC committee as well does fulfill that question for leapfrog.
I see another comment here in the chat box that says, prior to COVID, we had a secret shopper who were community members and our patient family committee. So I think she's responding to the question that Megan posed. Does your facility currently have a process in place for patient and families to report patient safety events? I see another comment in the chat box. We have a website link and customer service line through which patients and families can provide feedback, including concerns about patient safety events. And Megan, it looks like Chuck answered your question here. SafeLink is a reporting system for near misses, med errors, etc. from staff.
And I don't know if we shared one of the other comments. Our board level quality safety committee includes community members, highly recommended.
Yeah, I mean, honestly, your community members, especially on any committee that you have, they provide another lens with which they look at things other than, I'm going to say us, being a registered nurse, being a healthcare professional. If you're in it every day, sometimes you don't kind of see those forests for the trees because they come at it with a different lens and a perspective. So I think that's so valuable and important. And not only to have them sit on your committee, but have them feel empowered to ask questions. Because if they're just sitting there listening to reports and they're not interjecting and there's no, conversation or dialogue, it's not really going to be helpful. You need to empower them, to speak up and have the conversation and interject and comment. So I think that's fabulous. I also have seen I'm just going to throw this out there, that in terms of like identifying when you think something might be an event that's reportable, that you can like kind of garner that information from the patient. I do see facilities that, might have signage up, see something, say something, what have you. But I think, even like what Renice was doing when she was talking about what happens at, her facility, I mean, they solicit it. They're going out in face, in person, saying, what is it that we can do for you? And having that conversation, opening that door to have that dialogue. Because sometimes I think signs are great, don't get me wrong, but just like opening that door and even educating staff, and that speaks to culture, right? Because you're willing to accept, feedback from that patient and being able to address that. And having a facility that will take that information up to their patient safety committee or whatever PFAC committee that needs to work on that and to mitigate that problem. And then the feedback, because I think that both Chrissy and Terry, as well as Renee, said that there's a feedback loop to the patient, that's great. And obviously you can't tell them everything, but having that feedback to the patient, I think, is so valuable as well.
This is Terry. One of the other things I wanted to add is, in thinking about this, I didn't include it in my presentation, but Doylestown Hospital has a huge volunteer force. We have tons of volunteers, and it's amazing, the information we get from them. They are throughout the hospital. They are, they want to be helpful. They are really, a lot of times, first point contact to patients and families. I know many times it's the volunteers that refer the patients and families to me, or they will call, or I'll get calls from the main lobby because somebody's angry and they want to speak with somebody, and we try and do that real time. So, I mean, that might be a consideration too for anybody who's trying to find, different components to fill in some of the gaps. Utilize your volunteers. Our volunteers have been fantastic, and they're really open to trying to offer as much as they can as community members to the hospital. So just something to think about.
We are almost out of time. If anybody does have any final questions or comments, please feel free to type them in the Q&A box. I see another comment came in about our community committee members, our voting members with equal input as the chair and CEO. So before we wrap up, do any of the presenters have any final comments that you'd like to share with our participants on the webinar today?
Yeah, it's Chrissy. I mean, I guess start where you are. I mean, I think we hear these webinars and it's always nice. Like, I've learned a lot just from some of the dialogue, and, just starts with something. And, some organizations have more resources than others, and, but there's no good excuse to not at least giving it a try. So don't be dissuaded.
And sometimes you have to give it a second chance. As I said, I was not a PFAC fan. I'd be the first to admit it. And now I am the cheerleader extraordinaire. Like, I love this meeting. I love this group. They have great energy. And I really believe that they are going to create change within the organization. And I think these days we need that. We need some positive energy. We need some positive changes. And this has really worked for us. So, I have to say I'm a new believer. So don't give up.
Those are some great comments to end this with, because it's easy to want it to look perfect when you start out, but recognize that sometimes it doesn't have to. Be ready to adapt and keep moving forward. I think over the years, we've all heard probably some resistance to this area, and it's great to see, I think, where the evolution has gone, knowing that we have facilities across our state that have various degrees of resources that they can put towards it, but what can you do today? So thank you all very much for our panelists and presenters. This will be concluding our webinar. I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or certificate, please feel free to direct any inquiries to Shelley Meixel at shmixell@pa.gov. This concludes our webinar. Thank you.